Okay, cool. I am not a very good stand in one place kind of speaker, but I have to because of this microphone. So apologies, I don't get to entertain you with my walking back and forth. So for those of you who made my talk earlier, thank you. Even if you made half of it, thank you. Fair Mostyn. So I'm filling in for Deborah, who was unable to join us. And so I have a similar presentation to what she had, but mine's a little bit different, tweaked to more of what my day is. Doesn't go through my current day-to-day job, but I still try to do prior auths. I'm still very active in the advocacy community. Some of my disclosures, I have financial relationships with Medico and off parency, and I have other board and committee involvement, doing a couple different things. I just don't have a life. That's what it is. So here's my disclaimer. Please buckle up. This is an hour-long talk, and we are going to get through it just fine. I tell terrible jokes. You don't have to laugh, though it makes me feel better if you do. So we're going to go quickly over some biologics access, operations, and the advocate balance, right? Day-to-day in a clinic, what that looks like. I like to call it a marathon, but it's not too terrible. That's me, a lovely Photoshop picture of myself. I have lots of alphabet soup after my name. I'm a licensed practical nurse, a certified professional coder, prior auth certified specialist, and a board certified patient advocate. All that says is I kind of know what I'm talking about, but I'm always fighting for the patient first. I am the CEO of Medico CX, which is a physician purchasing group. I'm the president and co-founder of NAMAPA, and I am the co-CEO of the Healthcare Advocate Summit. So what's the big deal? Why are we talking about these biologics? There was another talk right before mine on biologics. You hear us talk about biosimilars and other drugs. So it's a hot topic, right? It is reproducing what goes on in the human body. These medications are expensive. These medications have shipping and handling and storage things that go with it, but they're across all different therapeutic areas. I primarily stay in allergy and immunology, and then dabble for fun in oncology and rheumatology. Biosimilars will offer even more choices for patients, as well as other cost points for patients. These meds are costing a lot. That's shipping and storage. Overnight, cold shipping, big boxes, lots of styrofoam, probably not environmentally friendly. You can have your opinions there. One missed vial or syringe can take many, many other injections to make up for that, cost-wise. So high dollar, low margin. I say no room for error. Some people say little room for error. So let's get the elephant in the room out of the way, right? Everyone is short on time, staff, and resources. Is anybody's clinic, facility, or job fully staffed at this point? It's the best joke I've told all day. We know change sucks. It does, right? Change is hard. Change is not fun. It requires longer days, more paperwork, whatever it is. Like change is just inevitable, but we got to get through it. Please don't ever tell me the words, "That's not my job," because I will make your job infinitely harder.
Amen. Oh my gosh, that is the best statement all day right there.
I have a very small, nimble team at Medico CX. Those are two of mine over there. And while we all have our designated roles, it is very much we all work together as a team. So even if it's not Mostyn's job to do something, he has no problem saying, "I'll help you and figure it out." That's the important part. Then complaining, right? And we don't complain about he or she doesn't do their part. We try to frame it in the mindset of, "Hey, I noticed you're struggling with this. How can I help you?" Or, "Hey, is there anything that I can lend a hand to?" Because sometimes people get overwhelmed. What works for you may not work for someone else. So there may be struggles. So instead of calling them out, saying they're a bad employee, "Hey, how can I help you?" And I'm not doing that when I really ask you guys if you need help. I'm not saying anything. And burnout is real. In healthcare, we've had a really stressful last 2 to 3 years. Yeah. We know that it has been all over the news. It has been publicized, whatever, but burnout is really real. So the goal is to think smarter, not harder. And I'm big on the phrase leaning in versus leaning on, right? I'm going to lean into my community. I'm going to ask questions, but I'm also going to answer questions someone else has, right? It's not a one-sided thing. You're not holding me up. It's vice versa. So why do we bother, right? It's the patients. Every pen stroke, keystroke, decision, conversation we have all comes back to the patients. This conference wouldn't exist. We wouldn't be here if it weren't for the patients, if we weren't trying to improve the lives of others. So this is why we do what we do. Physicians decide the most clinically appropriate treatment, and then the race for us to get them on therapy starts. We provide cost savings and that continuity of care, right? Because just because I may, as the nurse, have administered the drug, it still has to go to billing for the claim. It still has to go to copay assistance. That note is going back to the doctor that they were administered their drug. It's a whole team that's going through that for one person. And another reason to bother is time. Does anybody feel short on time right now in their life? Because again, I have no life. I went back to that. But yes, time is super, super valuable. So according to the 2021 AMA Physician Survey on prior auth, right? Then on averages, practices are completing 41 PAs per physician per week. So in my small corner of the world in allergy and immunology, I'm talking about biologics, the big expensive things. We're having to auth EpiPens, inhalers, these life-saving medical devices. But that insurance wants to know whether or not that patient can have it. So I think 41's low, personally.
I agree with you 100%.
A biologics coordinator. That is, even though I'm the CEO of Medico CX, I still identify as a biologics coordinator. We got our own little thing going, guys. And I call it biologics, plural, because I cover more than one drug. So that's my stance on it. But it is a designated role signifying the knowledge and expertise of the healthcare team member surrounding medication access specific to specialty meds known as biologics. I made that definition up. That's why there's no quote. So this is me. I'm putting my name on this, putting my stamp of approval on here. When I am teaching, training, or engaging with someone in a biologic space, this is what I ask of them, right? You don't have to know this day one, but I expect you to know this after a year on the job. So I know this is a lot. My daughter is a huge Harry Potter fan, which is why I have the Fantastic Beasts, but I'm big on fee schedules. So hopefully they don't come after me for that. But I expect them to know on the access side, insurance basics. You don't have to be able to tell me what the Medicare deductible is today, right? But I need you to understand the basics of it, that Medicare has four main parts, that what is the difference in pharmacy versus medical benefit. I need you to be able to tell me your local and regional payers. I need you to know what pre-service review is. And this is what I'm changing because everyone thinks pre-service review is just the benefit investigation or just the prior auth. It's all of that in one. You got to know everything that happens before you give that drug. The difference in white, clear, which is changing to gold, and brown bagging. Does everybody know what that is? The white, clear, and brown? So white bagging is coming from a specialty pharmacy. Clear or gold bagging is buy and bill. And brown bagging is when a patient picks up a drug from somewhere else and brings it to your clinic to be administered. Oftentimes the VA or shipped to their home. Fee schedules and where to find them. Most people don't know how to look up a fee schedule or aren't privy to that information. Fee schedules are incredibly important. Policies and formularies, billing and coding basics. You don't have to be able to tell me what modifier goes to what and how to code out to the 8th digit. I just need you to tell me that if your patient has chronic urticaria, it is L50.1. Just give me the one. Denials and appeals, copay assistance, manufacturer hubs. I like to talk earlier. They said instead of calling them hubs, we should call them support centers. I think I'm going to go into that one. And then clinical, right? I'm a nurse. I have a clinical background, but that doesn't mean everybody in medication access does. So high level should at least know what medications you're working with and their FDA approved indications. I know doctors write off label. That's like the words we're not supposed to say, but at least know the FDA approved ones. Any required labs or testing, and then managing inventory and adherence, which we'll talk about some more. So it's a lot, right? That's a lot for someone to learn coming into a job. So there's a way to measure this, and every coordinator is different. At the peak of my coordinator career, I had 750 patients that I personally managed prior auths, ordering inventory and copay assistance for. That was a lot. I also had a team of 12 behind me doing the other part of those patients. So I say experience plus volume, plus the region you're in, plus your resources, which is tech and support, is output of how many prior auths or how many patients someone can take care of. So there's a lot of pieces into that. There is a seasonal component to meds, right? Everyone loves January 1st, right? Favorite time of everyone's year. We call that the blizzard because that's when our fax machines are going crazy. There's paper flying everywhere. So that's different than what happens in the summer. Patients travel. Adherence and compliance drops by over 50% in most practices. volume, both of your patients and their number of therapies, and then your region, right? Do you have great payers in your region? Or I'm going to pick on Blue Cross of Illinois. That is the most difficult payer to me. Oklahoma, a close second. Health systems. Are you inundated with lots of health systems that do not send patients out places? Alternate sites of care. The infusion center world is on the rise, right? You may be referring everyone to infusion centers, or maybe one closed and they're all coming to you. And then the community. Resources, things like tech solutions. What programs does your institution have in place? Costs and data. If you're having to collect data for research or for reporting purposes, that can add a lot of time. And then does your provider support you, manager, manufacturers? If your manufacturers aren't, please let me know because some are here and I will make it known. We are a healthcare team, right? It takes multiple people to do one thing for one patient. You've got your providers, they've got to be able to communicate, and they sure as heck need to be able to document. Heard that in several talks today, like documentation's not great. We know. On the clinical side, you have your administration side of it, scheduling, bringing them in, and inventory. Revenue cycle, obviously for your claims and copay assistance. I love my rev cycle people because they can get data really quick when you're trying to look at how well something's going. And then patient outreach as well. So I'm going to go ahead and pre-ask the questions for you. These are my top 5 that I usually get. How long does it take to get a prior auth done? How do I know it's been approved? How do I know medication is being shipped? And if anybody can solve that one for me, that would be great. Who is checking claims? And then who do I ask for help? So why does it take so long? Well, there are 2 benefits back to that insurance basics. There is pharmacy benefit and there's medical benefit. In the pharmacy benefit world, man, it feels really good because you can get instant approvals. But on the medical benefit side of things, sometimes certain payers have up to 45 days to render you a determination. That's called a predetermination, and those are not my favorite. But
And they can still deny.
of course, and then there's a whole process to that.
Yeah.
And it depends on the type of review, right? There are still payers to this day that make you print that out and mail it in.
Yes.
So snail mail. And then depending on how you submit it, right? Phone calls, fax, there's portals, there's Cover My Meds, there's all these different things, right? And different ones work different ways. And then those payer review times. There's an overuse and abuse of expedited, right? We love that word expedited because we get a 72-hour determination. I think that's great. Not every patient qualifies for an expedited review, and then it backlogs.
Mhm.
So in short, we are at the mercy of the payers. Yes.
If you choose expedite, submit questions to you on a Saturday morning when you're not there, it will be automatically denied.
Exactly. Exactly.
So my favorite was Sunday afternoon. I'm strolling through Target with my son when he was much younger, enjoying my time, and I work from home. So you call myself and I'm going to answer. Didn't think they would get a hold of me, and I answered. Luckily, I'm not submitting as many prior auths, so I remember the few that I do submit, and I was like, oh, no, I got this patient. Let's talk about it right now. It's a Sunday afternoon. My other favorite are West Coast based insurance companies. And they
Yes.
call me at 6:00 their time, which is 9 my time. Oh, we're going to talk. We're going to solve it.
Yeah, you never not answer the phone.
Yeah.
Exactly.
And I do have in my voicemail that this is a confidential line, so they
Yes.
can leave me a message. So types of pre-service review, and this is important. Prior authorization, that's what everyone's most familiar with. Predetermination must be written. You can type it up and you can fax it in. That counts. That's the one that you usually have to mail. Medical necessity review, or ABD, advanced benefit determination, most commonly with payer plans, Blue Cross Fed. And similar documentation to a PA, you're just asking permission, not requiring permission. Oh, are you laughing at my?
Yeah.
Yeah.
He's heard me on the phone like I don't know how many times in 2
Uh-huh.
weeks.
Yeah. Just multiple questions. So going to medical versus pharmacy on the Medicare side, right? Who in here is really familiar with Medicare? Anybody? Uh-huh. All right. Okay. I nerd out on Medicare. So Part B is your medical, Part D is your pharmacy. You also have supplement or Medigap plans. That's your LMNOP is what I call them. You have Medicare Advantage, which is your squish together, or Part C. That has B, D, and put together, A, B, and D. You have patients that may have Medicare only. So only 80% of their coverage is paid for on Part B.
And
Um,
only if it's accepted by Medicare. Like,
yeah,
you know what I mean? It's crazy. And then you don't get your supplement to pay if Medicare doesn't pay.
we talked about that this morning. Yes.
Yeah.
And then, so some of the common ones that we find struggling in med access is your Medi-Medi or your Medicare, Medicaid, if patients need low income subsidy, and then foundations and other types of assistance. So on the commercial side, right? So Medicare over to commercial, you've got your medical benefit, you've got your pharmacy benefit, and there are these lovely forms that exist that you can swap things back and forth on those different benefits. They're multiple pages. Um, the distinction here that can be tough is employer based versus self funded. We're now facing what are called maximizers and accumulators, which on the patient access side are absolutely terrible. So it doesn't matter how much copay assistance you get, you're actually not hitting your deductible and still having to pay those things out of pocket.
They are.
They are, which is
Amen.
yep.
Yeah.
So Virginia, North Carolina, where I'm at, yes, they are illegal. However, when you get someone, even though the claim files through the local, but they may have like Blue Cross of Arkansas,
Yes.
rules still apply.
Yeah.
So that can be really tough. Copay cards or coupons, and that's the foundation, which these guys here, Dan and the whole track that's been speaking on financial navigation, I defer to them on those. Patient assistance is something that in the private practice world, I wasn't exactly privy to right away, right? I knew copay cards existed, but I didn't know all the different types of assistance that were out there. And so, in truth, doing things like Healthcare Advocate Summit, meeting people like Dan and others in this room, that's where I've learned all about the different types of patient assistance that's available. So, just when I feel like I'm qualified to stand up here and talk about this, I learn more. And I've learned more today. So check all patients for any form of assistance, right? As soon as I'm looking at a patient that I'm going to apply for an auth or enroll a drug for, I'm looking to see how they're going to financially get that drug covered right away. Are they underinsured versus a non-covered benefit? So we know uninsured, right? You have no insurance. There's all kinds of stuff for that. But this underinsured category is a little bit newer, right? Maybe it's a high deductible plan. Maybe it's a limited scope plan. But that does qualify for other types of assistance. Non-covered benefit, there's a lot of manufacturer programs or bridge programs we can use. Copay cards are the most common, but there are grants, there are coupons, free medication programs. Uh, I think in the Medicare Advantage world, one thing we default to is we're just going to use the free drug program because we know we can't get anything else covered. It's great. It's a great backup. What happens when the patient loses that or the patient changes coverage? There's a lot of things that can go into those free med programs. So patients who lose coverage or have major change should be submitted for new assistance right away. I am pro manufacturer hub enrollment forms. I know it's time consuming, but in the off chance, and it's happened more times than I can count, my patient loses coverage, all I have to do is pick up the phone and they're enrolled in free drug because they're now uninsured. It is the best way to keep continuity of care going so your patient doesn't miss treatment. And then, of course, document or record their support in an appropriate manner and make sure all staff knows how to process. It is really scary when a patient gets a bill in the mail for $5,000 and they're like, whoa, wait a second, thought I had a copay card. They call the office or wherever it is, billing department. They go, no, you owe this money because nowhere in the chart can you find that the patient has qualified for any form of assistance. So please, please, please document that so that they can see that.
That is the biggest struggle as an independent patient advocate. That does not happen.
Yeah, that's hard. That continuity of care piece. So when you're talking about how to get it for a patient, and the theme of this talk is a day in the life, right? So these are things that are running through my head as I'm looking at a patient on a case by case basis. And I'm trying to decide what's the best way to acquire that drug for this patient. So what's your preferred method of acquisition? I live in the buy and bill world. It's where you buy something and then you bill for it after you give it. Needs clarity there. Specialty pharmacy. What's the route of administration and the site of care? Is this sub-Q injection? Is this an IV injection? Is this an oral? And am I going to give it in my hospital? Am I going to give it outpatient? I'm going to do it in my doctor's office, or is it going home? What manufacturer help do I have? And then insurance. Is it even buy and bill eligible, right? That's my preferred way to get it. But can I do that? Or is there a carve out to the pharmacy? Are there any step edits? We all love those. Any formulary requests or any other types of coverage. So managing a buy and bill clinic. This is what I did for 7 years firsthand, and this is what I love. So there's a lot of pieces of the puzzle to it, because now you're making a personal investment, or well, your physician's investment into what you're doing. Right? One mistake again can cost you thousands and thousands of dollars. I've had 2 claims go very bad in my career, for a total of $10,000 a piece, and my physician wasn't very happy. Turns out it was not my fault. I went to the insurance commissioner and got those claims paid. But it was a very long 2 years of my life feeling like I had wasted some money there. So you buy it, you bill it. It can be an additional revenue line for your practice. It can be a very confusing revenue line for your practice, the way payments go. That cash flow cycle is absolutely critical to know. And the reason I say the cash flow cycle is important is you usually have 90 days to buy a drug, be reimbursed for it, and pay your bill. There are rebates and discounts you're eligible for. Those come in a quarter later. So there's really a 6-month cash flow cycle on these medications, and it's very hard to match up. I paid X for this drug and then got reimbursed this because it takes so long. It requires the same level of detail as any other biologics process if you're following best practices already. And it's not going anywhere. It's just getting harder to do, which is probably why I'm still in it. Crossing T's and dotting I's, eligibility, authorization, referrals, inventory management, and documentation. So I'm talking about this like this is a perfect world. This is what I focus on all day. In between this, it is running patients, it is phone calls, it is this. Go back to that first slide where we were talking about it's not my job or it's someone else's or complaining. It takes everyone to do this. If it's not there, it didn't happen in your documentation. Heather did a great job talking about that in her talk. If you don't see it, don't believe it. And then, so always remember, right? You're only as good as the rep you're getting on the phone.
Mhm.
How many of you had a benefit investigation go a little off track because of that? Nobody? Okay, thank you, Zach.
Yeah.
Thank you. So have you ever called multiple times, gotten 3 different answers?
Yes, 3 different people.
Yep.
Yes.
So picture this in your minds. You're calling somewhere, they're all in cubicle land or at home, one of the two. They literally have a binder or a screen in front of them with pre-filled prompts, right? Your question is this, here's their answer. And that's it. That's what they're going to give you. They pull up a patient profile, and depending on the department they're in, depends on their visibility. So you ask a question about a J-code benefit. They may not be able to see it, so they tell you it's not an issue. But then you talk to utilization management over here, they can see that and they give you a different answer. Be very, very specific in any questions you ask. Always document the rep you talk to, their name, the date, time. Yep. And if you really want to get technical, I ask for their extension if they have one.
Absolutely. And their full spelled last name if they'll give it.
Yep. And just write that down. It'll save you. The second thing to that is we're in a digital age, right? We're all hopping on portals, we're typing things in, we're getting stuff out. But you're only as good as the data displayed on the portal or website. And I know screenshots are a thing. It's kind of hard to do that. But that's it. So when you're checking eligibility and it says patient is verified, I do screenshot those and I file those away. I upload them in the patient's charts. But if you're checking deductibles, things like that, it's only as good as that data at the time.
Exactly.
Everybody loves the real-time benefit check stuff right now, right? On the medical benefit, that is very hard to do. You don't know if the patient has pending bills other places. So you're only, if you got a $500 deductible and they still have 500 left, but they went to their primary last week, who knows? So I give the patient the info that I see. There's some more stuff to document. We kind of went through those already. If they say no PA required, I ask a bunch of different ways. So I document all the different ways I asked as well. Communication, right? So yeah.
Like no prior authorization. Do you ever make a best practice to do a pre
Yes.
in those cases? Okay.
So if I ask,
Any sort of authorization,
oh yeah, I ask all kinds of questions. So if no prior auth is required, I ask if I can do a pre-D. They say no. I ask, can I do an advanced benefit determination? Can I do a medical necessity review?
Yes.
Is there any sort of voluntary review that I can do? And then I ask, will you hold my claims for medical pend? Or do I have to submit records with claim submission? So I go through all the ways they could hold me up in the process. And sometimes they don't have the answers to all those.
Exactly. That's the problem.
Yeah, it's tough. But the communication part is key. Back to being a healthcare team, we all work together. You're only as effective as the information you receive, so be sure to document it. Scanning in or organizing correspondence from payers. I think this is the one that trips up most of us, right? We see it's approved somewhere, or we call and they tell us it's approved. We never got a letter or a fax because it's buried somewhere in 5,000 sheets of paper. But that documentation is important. The scariest thing to me is when you have someone at a front desk or in a back office that takes scans and like shreds the cover sheets and all that. I'm like, oh, please don't, because on a cover sheet, I've gotten approval numbers. Please give me the whole thing that's coming.
Oh, yes.
Yeah, please don't edit my or sort through my faxes. And then think transparency, right? How can everyone in the practice access these valuable documents, right? So one thing I like to do is I use phone notes in EHR systems. Some people can send messages. Phone notes stay in a patient's chart. And I put the subject of my phone note as blank drug approved this date. Then I put all the info in that phone note. So when you're scrolling by through a patient's chart, you'll see visit notes, you'll see this, but you'll see my phone note with approval info in there. I also use that for inventory purposes too. Tracking is really important. So this is an example of a spreadsheet that I use. And then an example of off-parency, which is the software that I mentioned that I work with. But I track patient name, date of birth, the effective date of their prior auth, the expiration, if they're buy and bill versus SP, their type of insurance, diagnosis code. The reason why I track diagnosis code is it's very quick for me to find if somebody's trying to go off label, if a doctor's trying to get sneaky on me, or if they are on something like an unspecified code or a general code, that helps. So the value of off-parency is that all the data I would have to pull out of a spreadsheet is already in there. There's mandatory reporting. And I can also team assign. So when I have multiple biologics coordinators working, I can use this to see who has what auth in their work queue. And so it's a really quick way for me to identify which payers may be trickier based on time and who may need some additional assistance.
I use like the phone note. We renamed it like insurance note.
Cool.
I put the diagnosis in that note so our billers can see it. If sometimes the patient has 3 diagnoses,
Yeah.
so it's like which one did you get it? Sure, they get it billed.
And that's super helpful because when you guys administer, then you can look back and make sure that the correct diagnosis code goes with your administrations.
Because if you didn't have the
Yeah.
same code that you have to get the drug,
It's not going
when
to
you're
be that's okay.
administering something's not going to jive and they're going to deny.
Now, I'm going to ask you questions now. Do your like when you guys go and check those claims, do the scrubbers or whoever's looking at those? I guess that makes it easier for them than to double check. Like, do they go look at that stuff?
They do. They can see chart, and we have a little like they can pull up. You have a little search bar, and they can just hit insurance, and all the insurance notes come up, so they can see what diagnoses we used, who we spoke with. All of that information is right there.
That's really cool. Yeah. That's a great tip on that one because usually I just put approved. I don't even put the diagnosis code.
And we do, and because other people use phone notes, so we figured it was too much if they're looking through every phone note.
Yeah.
So,
is that a template that you guys have built basically, or like an individual? Okay. Yeah.
Certain covers, rain scrubbers, things like that. You're saying they came over like that on the super bill, and you're adjusting it. So, yeah, it's before the super bill. Like,
yeah, so it'd be in the patient's chart. So when they're scrubbing the claim, so like your coder would have to be when they go back in to look at the notes and all that, it would be in there for them to take a look at.
So that way, when the nurse attributes it to a diagnosis, when they're doing their when they're doing their documentation, and then the billers, it's all on the same diagnosis, and there's no deviation.
So like if you're an Epic-based system, Epic would have to give read-only privileges to your coders to be able to go back and look at those notes. Yeah, good tip though. So in a perfect world, right? Because everything in healthcare works on a perfect world. We take board tests based on a perfect world. Everything would run smoothly. We would never have these hiccups. But this is what a typical process looks like for accessing a specialty medication, right? You're doing forms. You're looking at payer policies. You're doing your BI, your PA, or whatever's needed. It's approved the first time around. That feels really good, but doesn't always happen. Patient gets scheduled. They come in. They're checked. so on. You give it, their claim is processed perfectly because a clean claim went over, and then they use their copay assistance if it was even applicable to the situation. I said that in about 30 seconds. That takes me 30 days. So some current hiccups that are going on right now, right? Time, staffing, we already talked about that. Specialty pharmacies. Now, I used to attribute some of this to all the shipping delays that were going on, just freight and other issues, logistics. But specialty pharmacies are overwhelmed. There's a lot going on. There are different departments, there are layoffs, there are hires, lots of things are changing. There are specific departments you can work with that sometimes ease that burden. There are small specialty pharmacies up to our big chains.
And if you have a change of health insurance,
Yeah.
literally, I'm on 3 weeks now of trying to update an insurance on a $10,000 med for MS, and I've gone 4 weeks without it and had a hospitalization. And there's nobody at this pharmacy that knows how to update the freaking insurance.
I would stick the manufacturer on them. That's what I would do.
Like, this is crazy.
I would call the hub, and I'd have the hub call the pharmacy because the hub pays the manufacturer pays the pharmacy to take care of those patients. So I would go to the manufacturer on that. Yeah.
So so you guys don't have your own specialty.
Some practices do. So my previous practice did. We had our own pharmacy.
If you're in the same building as an oncology practice, there's a good chance that they have their own specialty pharmacy.
Correct.
For you and the patients.
Yep.
A nurse can pick up their biologic at the oncology office and bring it up to their office. So,
which is called brown bagging. But yes, they could do that. And yeah, that's great. And the hard part is sometimes is as much as I love hubs and their benefit investigations, they give you the preferred pharmacy. There are such things as mandated pharmacies, but they give you the preferred. But a lot of times, yes, like oncology practices, they dispense to more than just in office. And you can go through there. You just have to know to ask that question and usually have the NPI of that pharmacy to where you can run that through.
Yeah.
Pro tip.
That is a great.
Yeah.
Yeah.
We're happy to fill for other offices, and you know that it's been stored properly, and you know you could easily pick it up on your way into the office.
I used to infuse for an infectious disease officer or office on the weekends, and they had a pharmacy, and they would do that. They worked really close with podiatry, and so the patients could come over on the weekends and pick stuff up. Some other current hiccups: portal fatigue. I understand that every website, every payer, everybody's got a website or a portal at this point. But I know that all of us will happily get on our phones and hop between Facebook, Instagram, Twitter, and Snapchat. So it's the same principle, right? Like you got to go different places for a different experience.
And that's great for us. But then you do the patient portal for your patients who are 65 and older. Oh my gosh.
You mean Medicare.gov's not friendly?
Even your doctor's office isn't easy.
Yeah. I'm still blaming COVID on some of these hiccups, right? Like COVID's still a problem. Take your opinions on that wherever you would like,
Sure.
but COVID is still causing issues in access.
Or being used as the excuse of causing issues.
Sure, either way. Policy changes. I have a new drug that came out in January, and it's still going through quarterly updates on policy changes. So I'm really just going to wait until January to see where that goes. Utilization management changes. This happens closer to the beginning of the year, though there are some companies that'll make a change mid-year. But this is when you get like the new fax number or the new phone number, or they've let everybody work from home now. There's that. The faxes, the new meds, things like that. The hardest part was when COVID hit and they pushed everybody working from home, right? We got really interesting phone calls. I heard chickens, ducks. Right. But now everyone's going back to the office. They've lost half their workforce. So reverse problem now.
Yeah, sure.
Some specialty pharmacy considerations, because I can't just dog on the pharmacies. I also have to support them. The organization and tracking of patients. I love to be able to call a pharmacy and say, this is my doctor's NPI. I need a list of all my patients who fill under that NPI, right? It's a great way to track adherence. Please tell me the last time they got a shipment. Refill times. Hey, my pharmacies are great in that I can try to sync all my refill times for patients, right? Like, can I please every other week get this set of patients? Every other week get this set. Not all pharmacies are great about it, but I work really closely with them to try to keep that in the same pattern. It prevents a lot of lost shipments. That patient office coordination can be really tough. You can tell your patients all day long, please answer 1-800 numbers. Doesn't mean they will.
They won't.
Yeah. So I tell the pharmacies that, listen, if this patient hasn't answered, please call me and I will reach out to the patient. I either have a local phone number or they know me, I can get a hold of them.
I do conference calling too.
That's great.
Because they won't answer.
Yeah, they won't. When I call a pharmacy, I always have multiple patients. So I try to do everything at once. And I pre-warn them like, hey, I have 5 patients I need help with. Can you help me with all of these? Most of the time they say yes. Sometimes they limit me to 3 if they're really busy. But you can get multiple things done at once. Does everyone know what a warm transfer is?
Yeah.
If you don't, please, 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 please adopt this into your language with insurance or anyone else. When they say, please hold, I'm going to transfer you, ask for a warm transfer. That means they have to get someone else on the line and then connect you.
Yes.
Because there's nothing worse than being on the phone for 2 hours and they disconnect you. So please ask for a warm transfer versus a cold where they just send you off and hope for the best. You're not alone in these frustrations. This is global. This is what's going on. This is just part of our job.
Add to that last one.
Yeah.
Don't believe that they'll call you back.
Yeah.
They will not call you.
Right.
No.
No, you live on a hope and prayer that they're going to call me back, like at the time they
phone
said.
number, and you won't lose your spot in line, and you'll get a call back. And like, no, that doesn't happen either.
What do you mean? They always call me back. Tech solution I always plug is RX Lightning. They're great for specialty pharmacy enrollment. So you can go on and fill out, works as a prescription. Your doctor signs an agreement with them. And so you can send it directly into the pharmacy. They have negotiated some direct service buckets for these pharmacies. So it gets priority access. Kind of cool. And it's free.
Free is free.
Free is great. Back to those kind of complicating factors. You've got copay accumulators or maximizers. I still think off-label diagnoses are a complicating factor. That doesn't mean that you just give up on them, right? I'm a big proponent of compassionate use. If you do not know what compassionate use is, it is for patients that do not qualify for clinical trials, but would benefit from this medication. And so you have to prove how and why they would benefit. And usually you tap into your medical science liaison for that drug. You get journal, peer-reviewed articles, and so on. Step edits and income limits. For patients, and Dan, this goes right into you, for patients that are right at that border or, they're in the spot where they may or may not qualify.
$2.
There's a lot of arguing that goes there. So besides the paperwork, besides all those things I've told you for that day in a life thing, you've got to keep up with your inventory. You've got to keep up with patient adherence and compliance. Our patients are pretty great. I know they're coming in every 2 weeks or every month. However, it's very easy for them to like miss a week, then they get off schedule, or they want to come a week early. Then I've filled more units or bought more units than was approved. So then I lose money doing that. So it is really, really imperative to keep up with their adherence. A knowledge upkeep, right? I've got all those alphabet soup things. I have to have CEUs for all those. So I'm constantly studying, trying to learn new things. If you've got a clinic or a practice running at the same time, phone calls, voicemails, EMR. And then, hey, guess what? We have personal lives, right? We have families, we have this. I drug my husband here so I could see him because if not, I'm at work. So inventory management can save your life. Ziploc owes me a whole lot of money at this point because I talk about Ziploc bags all the time. Mostyn and Sherry, I'm sure you're sick of me talking about Ziploc bags, but they will literally save your life in medications.
Yes, they will.
So I'm, again, buy and bill, don't want to lose anything. I store my drugs in a Ziploc bag with the diagnosis code and the number of units on there. That helps for billing. When the bag is empty, guess what? The patient needs more drug. When the bag is empty, I can then take a nice stack of bags and say, here, practice manager or biller, all these need to be billed out. They then can come and say, okay, now you need to order drug for all of these. So it's a great way to know what's in my fridge, what's not in there. I put stickers on drug as well. Most commonly, boxes say sample on them, but I don't know if you've looked at a drug box lately. The word sample is getting smaller and smaller.
Yes, it is.
So it's very easy to grab the wrong thing. And I know it happens in practices, it happens in hospitals, it happens everywhere. You've got free drug or a sample, you've got pharmacy stuff, and you've got stuff you've bought. There's a lot and expiration on every box, and that is tracked from every different avenue. I have gone through audits. It takes no time to pull those lot numbers and to tell you where that came from. Whether you bought it, it was provided to you free from the manufacturer, or it came from a pharmacy. Do not, absolutely do not take a box and say, I'll replace it later with something else. One patient, one box of drug, specifically how it came for them. They will find you. And please don't do this. Each one of those boxes of drugs are $5,000 a piece. So that is a lovely $25,000 stack right there with the word sample written all over them. That is absolutely not samples. We paid for those, but would have been given away for free. So in an audit, could we have caught it based on lot number? Yes, we could. Chances are it probably wouldn't happen. This is coming out of a practice that has 10 locations in Indiana. They have about 2,500 patients that receive these injections. So it can get confusing. Have a dedicated person to check those things. It is fun to run around with that much in your hand and be like, look what I did. I thought this would, feel a lot more. So my top 10 tips, right? If the dose is off label, please send that to specialty pharmacy. Review your inventory monthly. I'm digging through fridges every month. When I go visit practices, could be my first time in there, the first thing I ask to see is their refrigerator. I've got lots of pictures of them on my phone if you ever want to see them. Check your PA dates before admin. Store biologics labeled correctly. Know your diagnosis codes. Know your medication codes. Have patience. Probably should have put that first. Educate your patients on copay assistance. And then probably one of the most important is treat this process like an investment of your own. Remember, your time is valuable. And don't be afraid to ask questions and rely on your local manufacturers and reps. Questions, and I made it under time. Yeah.
You had experience with miscellaneous drug J codes before they turned to permanent J codes.
I mean, I really like those, yes. J3590 is my jam. What do you want to talk about?
Do you have any tips or things that we should do differently outside of the process you outlined?
So with miscellaneous J codes, if you're following all of those things, right, in your documentation, it really comes down to your claim form. And so doctors they have to document the day, like out of why the patient's on that. Is there a specific drug? So I can tailor. Ocrevus is fun. So it comes down to your documentation and it comes down to your claim form, right? Box 19 on a CMS 1500 is your additional box. And the more information you can put in there, the better. Also with your NDC code, making sure you have the correct unit of measure, right? There's a big difference in milligram and milliliter. So make sure you have it however the drug is provided. And because there's no published J code to that, it can be hard to find that information, but your manufacturer should have that. So what I like to do is create a sample CMS form for the practices that says this is what it should look like based on a typical payer. Asterisk, please check with your payers, but so they have that. But that NDC format is.
That's what.
Yep. One of my drugs was vial only and then moved to prefilled syringe, and there's still 2 formulations available. And so when that prefilled syringe came out, the vial was by milligram and they wanted prefilled by milliliter. And that just had to change everything. So we had to go and create internal codes based on formulation and go from there.
Yeah. My other question is about copay assistance. So there's been some buzz, especially with Cigna. Cigna is usually the good monster that likes to go back on their food. Cigna kind of has won some lawsuits related to copay assistance. That's subscribers, so once they have, it has to be paid with primary secondary payers. And their argument is that it's the patient's copay, so they should be the ones responsible and they should be receiving a patient statement to say this is how much you owe, and then they can use their copay card. Where again, practices usually just don't do that process; they just kind of run it for them. Have you heard much about that?
No, so we get around that, and it's through EDI connections. So in my small space, in the oncology space, you can now set up, so you'd have maybe primary and secondary or just a primary. You actually add that copay card in as a tertiary insurance. And so with the EDI connection, files to the primary, files to the secondary, whatever's left automatically files out to that copay card, and it comes in and you post it as a regular payment. So that saves a ton of time and gets around that because a patient has generated an EOB for each step of that process.
I think the way that they won this argument was that a patient received a statement for their balance.
Because they send the patient an EOB. Okay, you need a really, really great healthcare attorney, and I would absolutely fight that every day of the week. I have not heard that. I have had Cigna recoup on other things, such as they processed a pharmacy claim, yet they never mailed me drug, and then I did a buy and bill situation because they wanted to test the claim. And so they were saying the test claim superseded my medical side claim. And so I had to prove to them that it was in their own system that they had a problem. So I had to connect a Cigna rep to the Cigna pharmacy and let them hash it out. Cigna, yeah. Any other questions, comments, concerns?
Do you sign patients up for like low income subsidy, or do you use that?
Yes, I love low income subsidy. I don't personally sign patients up. I previously directed them to the Social Security office to do that. And so now I direct them to my buddy Geraldine, who's a Medicare benefits counselor, and I let her do that. Mm-hmm.
You're still
Where are you sending patients, Dan?
In our setting, we help the patient do it.
You do it?
It takes about 10 minutes
Okay.
on the Social Security website. It's very simple application. You don't have to send an proof of income.
So could I do that?
So
Okay.
can you repeat that? I'm sorry. So to help them with low income benefits,
Low income subsidy.
it's just on the Social Security website.
SSA.
So no, I have not done it myself. I always referred them out or sent them to a Medicare benefits counselor. But now that I know that, check with me next year. So Dan's group is going to come up and do a Q&A panel later this afternoon. That's going to be the group to ask all those questions to. Yeah, they will have all that. Sorry. Austin, did you have a question?
Answer.
Okay, good. Anyone else? Anything?
Can I?
Oh, hold on. I'll get Zach. Go ahead.
No.
Copay assistance, when it is being forced to another specialty pharmacy, and in my understanding, most specialty pharmacies accreditations require them to have some sort of their own process for finding
Mhm.
copay assistance, other help for patients. It's becoming more and more difficult to actually ensure that those payments get processed or that information gets applied to claims. Have you done any solutions in your experience for making that easier, or is it a space where it's safe to rely on those pharmacies to provide it? I don't think so, but I'd like to hear your opinion.
Should I get on the soapbox now or later? So manufacturers pay a lot of money to pharmacies as a contract to have them talk about their copay assistance options available, right? Usually that comes in the form of a copay card. There are foundations that contract and network with specialty pharmacies that they are supposed to say, hey, if you can't afford this, I'm going to automatically refer you over to either our internal foundation or one of these. Problem is, those funds are typically closed, or it's tough. So I think what really happens, I think that I'm going to say it's about a 50% attempt, maybe 60% to help patients because the want is there. But you're not wrong. They don't. I don't think they're getting the help they need.
Can I reframe it?
Sure.
To the call?
Yeah.
As a patient advocate in the middle of your daily routine, how do you, when do you let go?
Ooh, not well, first of all. Second of all, I'm a workaholic and I will sit at my desk and I will stay up late, or
She never wants that.
I do have to call enough. So if it's something and I can't get something for my patient, I am now to the point where I'll tag in someone. I'm very lucky that a lot of people at this event, I have their phone numbers and I will tag in and ask, do you have any tips, tricks, or advice? I also work the daylights out of these exhibitors that are here. And I say, listen, I need help. So when I call you, please help me. And I do that. But when do I give up is like when I've been told no 3 times. That's usually my.
What I'm hearing is you don't trust that to happen for your patients.
No, I don't trust. I do it myself. I would rather call the pharmacy and say, hey, I got this for my patient. You better honor it. And then fight them on honoring it than trusting. I'm sorry if anybody works at a pharmacy, trusting that they're going to get it for me.
Well, and I don't really think it's the pharmacy's fault. So I
think
hear
it's lack
you.
of education.
And like you said, just like when we're doing other things for approval, it's some person reading some screen in front of them on the questions that you ask, even when you go to a specialty pharmacist. And let's not even talk about if they can't speak English.
And I'm petty. I think I told you that earlier in my first talk is I'm a petty person. And so when I get someone on the phone at a pharmacy that doesn't know what they're talking about, the first thing I offer them is consultation and training. And I come in and provide.
I love it. I love it.
So if you can't take care of my patient, I'm going to do it. And you're letting down the health system. But that's just me. Yeah, sorry. Get me off the soapbox up here.
Within the pharmaceutical company to get compassionate access. Um, when you decide to go that route, um, do you go for financial reasons only, or because we're not from here, we're from Canada,
Yeah.
and in order to get that access, it's for off-label only.
It is. So compassionate use is for off-label use that they can't get into a clinical trial. So if I'm trying to get something approved, and even if it's off-label, I start with trying to get it approved through their insurance, especially if there's peer-reviewed information out there or published articles. But if that doesn't work, that's when I turn to compassionate use. For free drug, if I know for a fact my patient meets all of the on-label requirements and they're just flat out being denied, that's when I tag in manufacturer resources and give them free drug.
Okay.
So there are some manufacturer programs that will cover off-label denials with their free drug program. So sometimes that's pretty easy and I don't have to go to compassionate use. But
To denials, you need to.
Yeah.
You'll deny. Manufacturer.
Correct. And a lot of times I see it most commonly in abuse of free drug programs is not understanding medical versus pharmacy benefit. And so the patient can't afford it on one benefit, but it could be covered on another. And so they just get the patient on free drug. I'm happy the patient's on drug, but I'm not happy because we should have done it the right way because I don't want those programs to go away. Right? Like I want free drug to be a thing.
Sure.
Because there are people that just won't qualify some places.
We work for that needs to scan business too, so
Yes.
we
So-
supply the medication. We
Yeah, I'm still good.
medication.
Yeah.
So,
Can I address
Of
one
course.
issue here in regards to will stand up? So there was a comment that you made that when we have people have Medicare Advantage plans with a high out of pocket,
Mhm.
and one solution to that is just to get free drug for them, right?
Yeah.
I'm going to push back on
Please.
it. To hear what your thoughts are. Not every patient, but most oncology patients. So they're in a Medicare Advantage plan. Let's just make something up here. They have a $6,000 max out of pocket. They need, I'm going to make it up, Keytruda. And patient says, I can't afford it. There's no copay assistance foundations available. So the manufacturer will say, well, we will give it to you free. For oncology patients, what are the odds that even if you're getting free Keytruda, if you want to use that, what are the odds that they're going to hit their max out of pocket anyway during the year?
Right.
Yeah, it's high.
So what have we accomplished by getting free drug for them? And actually, I'm going to argue that we've made it worse for them because you still have the potential that a copay assistance foundation opens up. Some of them are retroactive back 6 months. TAF goes back.
So you're saying they can use their copay first and then?
So it's like if we do the free drug for them under that circumstance, we've taken that off the plate. We can't do retroactive copay assistance. Plus, we're getting free drug. We can't bill for it. If we don't do free drug, usually on these expensive drugs, within the second or third treatment, they've now met their out of pockets for the year. You're buying and billing. It's not about necessarily about.
It's Medicare optimization right there.
Yeah.
In some ways.
In one way, it is Medicare optimization. It is more optimal. Man, Dan, just when I'm confident in myself, it is more productive for the patient to use that assist or to use their plan than to get free drug.
And
you're saying if it's the buy and bill plan,
Correct.
patient can say, pay you guys $250 a month, whatever it is,
Mhm.
and pay off at $6,000. But if it's through their pharmacy benefit, we are legally obliged to collect the entire copay at the time of dispensing, and our patients don't have $6,000 generally. So
Yeah.
it would be a buy and bill, but if it's something on the pharmacy side.
Correct.
And I think it points back to,
Completely different from the pharmacy.
I think it points back to, and something that I think we get caught up in and forget is that each patient is individualized, right? Every patient is different. You can't just say Medicare is Medicare, Blue Cross is Blue Cross. Each one has its own thing. So I think it just further points back to that continuity of care. Like, we've got to keep this going. We got to keep addressing our patients on an on a case by case. So, all right, thanks you guys. I'm gonna run out of time and get in trouble.
Thank you so much.
I think a picture of